Care as One is committed to providing a unique virtual collaborative experience for healthcare professionals to come together to exchange information about U.S. healthcare through collaboration, conversation, and knowledge sharing. The Future of Health podcast provides a true infotainment service that helps the industry innovate by sharing expert voices, views, and advice on the important issues of the day. And now here's your host for The Future of Health, Dipti Desai.
Hello, everyone. Welcome to the Future of Health with Care as One. I'm Dr. Dipti Desai, the CEO of Care as One and the host of this podcast series. For those that are new to Care as One, it's a large virtual community that comes together and jumpstarts innovation acceleration by bringing together various stakeholders in the care cycle, from providers and payers to pharma, clinical researchers, startups, investors, universities, and many more. The mission of Care as One is to truly accelerate adoption of innovation by creating this connected health community where the patient is at the center of care. And the entire ecosystem comes together through knowledge sharing with the help of healthcare luminaries and thought leaders to discuss the challenges, the gaps, solutions, transformations that are essential to make healthcare whole again. This interaction and networking between the stakeholders is made possible through various ways like summits and webinars and roundtables, leadership circles, and yes, even podcasts. And we are here to do one today. And in today's podcast, I will be talking to Alex Yarijanian. He's the CEO and founder of CareNodes. Alex brings to us a decade of experience in serving the healthcare industry, and he has led teams across a national health plan, about 45 different medical centers, 14 plus hospitals, 50 plus skilled nursing facilities, and even home health agencies. Actually, Alex founded CareNodes in 2018. And then the pandemic hit in 2020, and it became a national healthcare organization by 2021. CareNodes even received the Best in Class awards from HealthNet and ComPsych for its pandemic response. And Alex owns a website where he shares his experience, his achievements, and contributions in improving healthcare. So truly excited to have Alex here with us today. And the theme for today's conversation with Alex focuses on the rising need to bring the payers and the providers together to streamline healthcare delivery and improve the quality of care. As you all know, digitization is the buzzword in healthcare. It's already transformed the way people shop, travel, and manage money outside of healthcare. But until recently, it hasn't made a major impact on the healthcare delivery. Today, all that is changing, as I'd said, and healthcare's digital transformation is centered on improving mostly patient experiences. And then, of course, we've had this rise of value-based care where both providers and payers are administering care from a quality perspective while keeping a sharp eye on cost. Cost, quality, care experience are all essential elements that make up the entire landscape of the 21st century healthcare space. And add to that health equity, and now you have that quadruple aim for healthcare. So we'll talk about all of this and more. And I'm really excited to have Alex with us here today. So welcome, Alex. It's a pleasure to have you here. And, it would be great if you, to begin with, you could share with us your journey and healthcare, and also talk about CareNodes, what it does, and what your role at CareNodes actually is. What is it that you do?
Thank you so much for teeing that up. Dipti, I'm very happy to be here and having, this dialogue in a way where hopefully there'll be actionable items coming out. My experience in healthcare has been such that for over a decade now, definitely as of 2010, when the ACA, aka Obamacare, went into effect, we talked a lot about value-based care and and so on, quality, the triple, now it's quadrupling. Next year it'll be more. But what kind of progress are we making given the fundamental infrastructure, the business models that are set up around kind of carving out the flow of funds That's really the challenge. That's really the discussion today, as you nicely framed it. And the journey that I've had personally in healthcare has brought me to to where I am now by really experiencing from the outpatient to the hospital to the post-acute to the health plan side management, and seeing across the country what kind of opportunities there are. And really, we're in the United States, we're dealing with 51 different mini countries, right? Kind of 51 different Medicaids and so on. So having this complexity where you don't have time to think about the patient, right? So there's a lot of this, marketing around patient-centered, this and that, and it's great, right? But where is the actual movement, right? When we're looking at disparities. So CareNodes came into life, like you said, late 2018, to really address certain gaps in care that had to do with directory inaccuracy in terms of Medicare Advantage plans and so on. Now, what happened was that, as you said, COVID hit. We all know when. And it catalyzed our business models such that we were able to implement an accelerator arm to our organization and help digital health organizations and their backers really be effective in going to market and bending that learning curve with an actual 4-step model to go into market in a way that has clinical, operational, contracting, network, financial, and compliance support, kind of turnkey, so that these folks are able to actually bring innovations to market without the long B2B sales cycle that's healthcare that tends to kill these innovations, right? Because the traditional healthcare folks, as you know, we're not digital savvy, we're not tech savvy, right? I mean, when COVID hit, Zoom was scaring us, and we still struggle with it, right? So we know the problems, we deal with it. We have to manually massage the Excel sheets and so on. The technology people are not familiar with our business challenges, unfortunately, to that intimate level. Very brilliant people. But when you're not intimately familiar with the day-to-day of healthcare administration, which is not cataloged anywhere, and it's certainly not standardized, then you're going to hit challenges, including billions of dollars kind of invested, but not really getting to the folks that, the investments are made on behalf, which is the patients. Ultimately, right? You have to capture patients and retain them. And if you're providing, in at least in theory, quality experience, then the patient will then be retained. So what happened with CareNodes is that, as we grew, we kind of started to transform into a managed service organization for digital therapeutic organizations, so that we're able to take delegation of all of this administrative headache that I probably gave you and others on the call, and take these complexities away and allow them to do what they do best.
Yes.
And simply make sure that the payer contracts are in alignment, right? The patient won't get out-of-network bills simply because they got their mental health services at the same place they got their primary care services, right? That group needs to have 2 contracts. So what happens is that all of this complexity then starts to be a barrier to supply. It starts to be really a barrier to care then, right? So what we've been able to accomplish by bringing this kind of provider simplicity model and standardized go-to-market is that now we have over 51 million Americans covered by the virtue of our contracts, over 134 health plans contracted. We manage 10 medical groups. And across the country, we have a national coverage, providing very innovative solutions. So essentially, these groups have to go through almost NCQA-like vetting so that, they meet the muster, and we have a clinical leadership that does that. I have no business making any such decision. You wouldn't want me to, right? I wouldn't want to. So essentially, dementia care, diabetic foot stocks, where female-invented, U.S.-made, right, based in the Bay Area, detects proactively potential onset of any issue that might exacerbate into amputation for diabetic patients. And 91% of those amputations were avoided. We worked with a recent biopharmacist, recently $1.2 billion organization valued. They closed a Series D round, backed by Aetna and CVS. They provide state-of-the-art cardiac monitoring and are really able to invest in the Medicaid population. So I could go on about the,
use cases.
groups,
Yeah,
but I'll
right.
stop.
That's so good. That's so good. What you're saying is that you actually bringing the ecosystem together. Like that's essentially what Care One would like to do too, is bring everybody together and bring efficiency into the system, which we are truly lacking today, right? And you see that tug of war is happening. Payers and providers do have common goals, but they have their own ways of doing things. But we've also pushed them to join forces under value-based care, right? And Payvider is this new term that has come about into existence, where payer and provider have to come together to deliver cost-effective healthcare services. And you work with these people all the time. So to you, what is your definition of this term Payvider? And do you think it's going to be an effective way of doing work? And I mean, you're already doing something. How do you see this panning out?
Yeah, absolutely. Again, as characteristic of you, you teed it up very nicely, where you said, kind of the adversarial legacy type relationship between payer and provider, has really been reshaped into having to align because of complicated things such as risk score and so on. So, systems have over time, although slowly, have shifted to, align the payer and provider more or less. So that evolution has kind of progressed into combining almost the two in a way. So that you have now these Paybiders. Now, not sure whether there's an actual definition, but this is my definition. The definition that the Payvider should have is that what we're seeing is in California, there's been this model for some time. You see in Florida and so on. The model where the payer, the top line payer, for example, let's say the Humanities of the world and so on, push a certain amount of their financial risk down to another entity and expect that entity, such as the medical group or, again, depending on the state, it could be any type of, depending on the state, the entity type is a different conversation. For that provider to be able to both manage their finance as well as the care. And so, this isn't a new concept per se, but what's happening is that you're now seeing a trend of actual provider groups directly contracting with payers that are such as Medicare, such as employers, and starting to kind of minimize the role of the bigger managed or care organizations. And it's interesting because if you look at what the managed care organizations are doing, for example, again, I'm going to say Humana, because they're actually adapting in a way where they have to kind of take the reverse approach. So you see provider groups kind of becoming Payviders, trying to be payers in a way. And then you're seeing that the market forces are requiring the Humanities of the world to kind of do the opposite. So you're seeing medical group acquisitions. So that for example, again, I'm going to give Humana as an example. Kindred at Home. You're seeing Aurora, which is medical groups, PCP groups that were acquired. And so the Payvider, essentially, if there's 3 points to it, I would say. So this is the most recent term that we're using for risk-bearing organization, because risk-bearing organization is very technical. RBO is specific to also California, and would get technical. It's not technical. The idea being that health insurance companies are furthest removed from the point of care. They financially are disadvantaged potentially because the risk adjustments that happen, from the Medicare level down to the Humanas or the Aetnas or the Cignas of the world level that work in the Medicare space. So the health insurance being furthest away, then the expectation is that these independent providers that are spread around, oftentimes they don't even like the insurance company, for them to do all the legwork that's necessary for the big health insurance company to get their disease burden of the population adjusted so that they can get additional funding if their disease population, their population had a greater disease burden than versus what they projected. So what happens is in the reverse is that if the provider network isn't actually collecting all the data from the patients or chronic conditions every year, they have to be documented. So if you had a chronic condition last year, it's likely you had it this year as well. So the rate of documentation every year matters. So the health plan gets millions of dollars at stake for that exercise. So for them to have tighter kind of control over accuracy of capture of these risk scores, which comes down to how well are you documenting your patient profile, that then essentially requires the plan to become closer to site of care. So that then becomes the Payvider pushing premium close to the site of care.
Yeah, you just nailed it. You said, on one side, you want to improve the patient outcomes, and that side, you want to optimize the finances. And those are the two most important fundamental focus areas that the payers and the providers need to accomplish jointly by working together, right? And if they do that, they can significantly reduce time consumption, the resources needed, all the duplication of effort, reach the goal in value-based care, right? But
Absolutely.
Don't you think the Payvider vision should be beyond the objective of just bridging information silos? It shouldn't be more like streamlining processes, also coordinating care. And also the ultimate goal is always improving health outcomes at a reduced cost, right? So do you see all of that happening downstream too, or people still stuck upstream to getting, alignments happen?
It's market specific. I would say Colorado is more ahead of the game than some other markets, such as Florida. California is highly complex because of this multiple layers before you get to the provider level. I would say
you said it. We have the 50 different health systems, the 50 different states,
51 countries.
Yeah,
51 one by one.
Yeah.
It's important that value-based, these Payvider, and again, it's like who's going to drive all of these? Again, it's really state-specific at that point. But market and patient engagement, community engagement should really be a robust Payvider, should be part of a robust Payvider strategy. Because community engagement, if you have boots on the ground, for example, Promodoras or community affair or health fairs, and you're able to not only acquire patients, but also be able to go to a payer and say, hey, I have this many, for example, Medicare fee-for-service membership. We know we can take care of them. And start to actually engage the payer, again, within the community engagement layer. So patient, payer, and start to really have a technology at home approach, right? So how do you push tech? How do you push care at home as appropriate, and use a biopsychosocial model of care so that you can actually manage the Payvider approach is really another word for risk, right? So getting these organizations that are typically providers and having them now manage risk like insurance companies would, really needs to have an approach that allows funding for a network, allows providers the ability to negotiate elements that they might not even know they can. So all of this is important for the readiness to become Payvider. So it's not just quality, it's not just the experience, they're just some elements, right? But are you ready to deliver? Yeah. How aggressive are your goals? What's the opportunity?
Yes, it's kind of like a culture change, right? Really, people, the insurance companies are risk takers. But the providers are not, they're risk averse. And you really need to change that culture there. Say, well, you need to also be bought into the risk over here. So that tug of war can not be there. Like, one wants to just get the money and the other one wants to minimize the cost. You can't have both happening. And you have to figure out how to effectively collaborate with one another to be aligned and achieve better outcomes, and be prepared for the next decade of value-based care, right?
While financially viable, absolutely.
Yes, everybody needs that. And becoming efficient and reducing the layers, I would say that would help a little bit. But maybe also technology can help. Maybe by changing the infrastructure, such as adopting cloud technology, using advanced analytics, AI, those can address the current inefficiencies across the health systems and healthcare networks and allow organizations at risk to become more successful. Do you see that happening?
No, I don't see it on the administrative side at all. I'm not seeing it. Value-based operations are not being discussed. I'm sorry. What you're asking is value-based operations, right? Is what I'm hearing, is how I'm seeing the totality of value-based needs to include value-based operations. So no, I'm not seeing any such stuff. Like we work with multiplicity of EMRs, perhaps I won't name them, multiplicity of clearinghouses, entities that are purchased by, for instance, Optum, which I'm happy to name. And they still have very legacy approach. So I wonder if it's the lack of incentive, right?
Yeah.
What's the incentive for operational efficiency, for example? If everybody should focus on risk scores and these things that actually then, you can show the executives on a slide on a quarterly market review and see what we got. Operational efficiency, okay. Right, so then that's when it becomes down to human factors and the conversation.
Yeah, you're right. We do have technology that exists to serve, but it's the people who are often resistant to adopting the technology. As you said, the incentives are often not aligned, and also sometimes they've been burned in the past. We've already invested so much into these legacy systems that exist, but they can't do what you want them to do today. So do you think that the biggest impediment to the Payvider movement, is it probably technology, but it's more like the culture of change? Or do you think adoption of technology is the challenge? What should change? What needs to give in order to make this all work?
That's a great question. So building technology for the sake of technology is not the answer, right? There are a lot of portals and stuff out there, I'm sure. But when you're looking at what is the issue is in terms of access to the market, it's a language barrier foremost, right? So you have folks who can build the technology, but then, the drop downs don't really match up with all the intricacies of being in network and whether this and that, the copay, this and that, pulling from this. So suddenly it's not a viable solution for an enterprise, right? So if I'm sitting at a health plan or at the provider group at this executive level and I'm getting a deck that says, for instance, we're going to reduce your hospital admissions by this many and save you X dollars, but I'm at a plan or a market that has totally pushed the risk down to now Payvider, and I'm not picking up the bill for those hospital admissions, and I'm not that interested in this verbiage, right? So you don't know your customer. That's the thing.
Yeah.
So there's a big barrier between the way the pricing is put together on this slide, and they're sent from the technology people who know what they're doing, and then the person receiving it doesn't really meet the business need. That's been going on for such a time. So that's really the barrier, language. And
you nailed it. You nailed it. And the software companies think that they're solving a problem that is needed, and that is a problem that exists. But when you go talk to the customers, they have moved on and there's something else that is actually plaguing them. And so people like you, CareNodes, actually that understands both sides of the coin, are the ones that are coming in and are actually figuring out what solutions need to be created, what are the things. And maybe sometimes it's not even a point solution that the organization needs. Maybe it's more like a platform play. Would love to hear your thoughts on how is it that you are bridging this gap between the solution providers and then the solution users? Would be great to hear a few examples where you made lives and also reduced time to market for these early stage startups or companies that are solving problems for the healthcare industry.
Sure. So there are different angles to the question. So I will say for our solution users, that will be the health plans. And the users, the health plans would be using our medical groups. And essentially, as a platform, CareNodes provides a a la carte and almost single source place for the health plan to say, hey, yeah, I need dementia care. I need, diabetic, but I don't need, mental health for foster children. So they have a single source that, for example, we partner with Mommy. Mommy is an amazing organization, Doula Network. Backers include Serena Williams, Mark Cuban. Amazing team. Maternity care, we're in conversations. I can't disclose with which organizations, but large payers that are very excited about providing finally maternity care to our mothers.
Oh, yeah.
And so now they're realizing, and so now there's a movement towards bringing doulas into the reimbursement spectrum to reduce C-section. So now in 2022, and so we have some plans that are interested in that. So what is the operations behind that? So as a user of the solution, the health plan, and the solution being the doula network, along with all the elements of that program, Mommy. Okay, the doulas, do they even have NPI, the identifier you need to even submit a bill to get paid, right? So the health plan now has to one-to-one contracts, and it's a lot of admin work. So here, boom, CareNodes is a centralized place that knows how to coordinate with the group, all the elements, has appropriate delegation to do so, coordinates in a streamlined fashion, and the user, the health plan, is able to distribute that solution using the medical group. So we don't do everything, right? The medical group then gets to spend their time actually getting to the patient. The solution that's now paid for by the health plan.
Yes. No, that's great. I mean, that's essentially what this convergence of payer and provider roles is bringing. We are seeing more and more providers willing to take on that risk, and then again, we need to identify the areas where what should be the top priorities for the providers who are taking on risk. What will be that new direction in a market that's permeated with risk sharing arrangements, right? And we need to identify areas where they can. And maybe you can talk a little bit about value-based care and also about providers taking on risk. It's a spectrum, isn't it? There's some that are like maybe a score of 0 and some that are closer to 10. Can you elaborate a little bit more on that?
Sure, absolutely. It's absolutely a spectrum. Folks should follow the spectrum. And the reason for that is because it's graduation to being able to manage complete risk. So how did it start? First, we're at the fee-for-service level where you submit a bill and you get paid, and hopefully they won't take it back if you did it correctly. The next level is you do the same thing, and if you did well on XYZ outcomes, the patients have less hospital visits and et cetera, then you then might get a bonus that's specified in your contract. Next level, and if you don't do well, then no harm, no foul in essence. Next level is when you actually start to have some skin in the game, in sense where your pay might be reduced if you don't meet those metrics, but also increased if you do. So you get more upside, more downside. And the next level is you stop submitting those bills and you just get a lump sum for the number of number of patients you have, and you take care of it. The bullet point things you put on your contract saying I'll do X, Y, Z for this amount of dollars. And if it's a transplant, you'll have to pay me separately. You meaning the health plan that you contract with as a provider, do a 3-year, 4-year deal on a graduated pathway. That's like my number one advice. And pick opportunities to have the greatest area for change. So if a health plan is doing 98, 99% on metric Z, well, maybe don't choose that metric, right? So the greatest opportunity for change.
Yeah. No, we've accomplished so much, and you're right. I mean, it's a gain, right? If you do good, then you gain more. If you don't do, then you lose more, right? And so much has been accomplished. Of course, we still have a long way to go. But if you were to envision the future of health 5 years down the lane, where do you think you would like to see healthcare go? Or what would you be your number 1, 2, 3 wish list of, like, I wish this could happen better or that could happen better?
If I could do it, or what will actually. If I were to be able to actually effectuate, we would have a more resilient country and a more resilient global community by the virtue of having less administrative burden on the healthcare providers. So more unified and uniform way of accessing critical data that you need to navigate practices that, you know, are just more than local or regional. And the ability to really have portability of data so the patient can actually move with the, you know, have their data from state to state. For example, if we're going to talk about addiction and etc., then by this time, 2022, almost 2023 now, we should be able to have at least a centralized place where a patient goes from state A to B, they're able to at least not get the same medication twice. So kind of a more coordinated approach to providing total, community care, in the sense where a community is more than just where you are, within the neighborhood.
No,
that would
that's
be
so
my vision.
right. That's so right. You should be able to take your care with you wherever you go. I mean, we're just talking about within the country. It could even be global, truly global in the future. But I think we have a
5 years.
long way to go. Yeah, but at least within the USA, if the patient had access to their data records and could move them from one organization to another. But for that to happen, you have to have a lot more interoperability to happen. You have to have more openness between organizations to share their data, and another can of worms. So, no, but this is great. I think we've covered a lot of different topics today. And I know that there's few that we may not have covered. Is there something that you would like to add or bring to the audience's attention, things that are of importance or things that really you care about?
Yeah, what I care about are actionable, timely solutions, right? So for example, I want to encourage the community to think about ambient assisted living, right? So as the population ages such a dramatic rate, we need to be able to take care of not only also ourselves, right? And we need to build the infrastructure right away. So we're already working with hospital at home provider with CMS waiver, including with UC Irvine, our RWJ in New Jersey, Brigham, and go on. But it's important that we start to think about, okay, well, if grandma is sitting, lonely because there's less youth and far more elderly, then her chances of a heart issues increase by 30%. Then is there some kind of a monitoring mechanism so that we can know remotely to intervene to the patient? What will it look like in the future where you have so many aging? So I want us to think about building a resilient society tomorrow that starts today. So where we actually think about, okay, well, through individual transformation, it's not all charity work, or you don't have to be altruistic, but through individual transformation, so you could achieve your own personal and professional aims. How can we transform our society? So next time a pandemic hits, God knows what severity, we're able to be a little more resilient. So people around us are resilient, and in turn, we ourselves are more protected. And this kind of thing takes some time. So we have to be less, in our conference rooms and in our echo chambers, and more about, okay, out of this, discussion, what are some one or two things that could be done next? And so if we can think like that, I think we'll make huge progress, because we have a wealth of collective knowledge and skill and expertise.
I agree. I think that healthcare is essentially sick care today. And we really need to transform it back to the healthcare, back to care at home, back to where people can take best care of themselves continuously on a basis, in the presence of their loved ones or in the presence of people like them, where because of that, chronic diseases hopefully will disappear, or they're monitored more regularly and therefore will become less of a problem. I would love to see things like that. And I think you really are on the right track over there by working with home hospitals and home care, I would say, for the elderly people, managing their chronic conditions better. So I think this is awesome. I think we really need to continue that discussion. And maybe the next time we meet, we should have some more conversations on how do we essentially take better care of our health at home as opposed to going to the hospital. But thank you, Alex, for taking the time to chat with us and discussing this whole convergence of payer, provider, value-based care, fee-for-service, and hospital care and versus home care.
A long list.
Truly.
A long list.
Yes.
Thank you so much for the opportunity to not only have this, but to also share this wish for us to all really propelled into action. So I really thank you so much for the opportunity.
I agree. I mean, I think on dialogue into actions and can do on these areas. The whole idea behind care to bring the whole community, stakeholders, be it the payers or the clinicians or the biotech, startups, all on the same page, so that they can collectively connect, create better care for it. So thank you. Thank you to the audience too. Thank you. And don't forget show notes and links to resources and contact information related to today's podcast. So stay tuned for more podcasts and discussions on care topics that you can send in your suggestions and speak on topics, and we will them. And thank you very much once again, Alex, and thank you and have a great day.
Thank you.